Hi guys. Excuse me. I hope that you're all getting some quality time in studying. I know there's a ton of material for this exam, which means that everything kind of gets diluted out a bit, and not when anything is particularly focused on. So I just wanted to review some of the highlights that we talked about in class, and some of the things that people have been asking me about since Wednesday. So I'm going to break it into the urinary system and then the second part into the integumentary and allergy. So your kidneys are solid organs, meaning that they are full of blood rather than hollow organs that are full of things like gas and digestive juices like your gallbladder or your stomach or your intestines. And the kidneys are retroperitoneal, meaning that they are behind the peritoneum, so they're located in the back of the abdominal area, and they're guarded by the ribs in the back. We talk about the costovertebral angle, where the ribs and the thoracic spine come together. So kind of your mid-back is about the area where your kidneys are, but you can palpate them through the stomach, as it's shown in your book, with a significant amount of pressure, and remembering that we don't typically do that at the RN level. That's more of a physician or advanced nurse practitioner level, because deep palpation of the abdomen can be dangerous. So the main role of the kidneys is to filter, and they filter about 125 milliliters a minute, which is roughly 180 liters a day. So that's how much water they pull out a day. But at the same time, they only excrete or eliminate roughly 1 to 3 liters per day. Okay, and in that, they're taking out sodium, some potassium, and water. They should put out at least 30 milliliters an hour, right, for normal kidney function, and then they reabsorb the other 177 to 179 liters every day. So while excretion and elimination is important, reabsorption is also critically important to normal fluid volume balance. They're important for maintaining acid-base balance with the bicarbonate, and maintaining body fluid compositions. Remember that blood urea nitrogen, or BUN, is a measurement of how much urea is being excreted or not excreted from the body. Here you go, Nate. You're welcome. And as that gets higher and higher, more and more proteins that should be eliminated from the blood that are waste products. Urea is a waste product, and it's a protein waste product, are not being excreted. So that's an evidence that the kidneys are not functioning. But remember that BUN can be caused by other things. An elevation of BUN can be caused by trauma, sepsis, cancer, dehydration, anything that could cause pre-renal or intrarenal kidney failure really can cause an elevation in the BUN. The creatinine, however, is very specific to the kidneys, and an elevation of the creatinine is typically related specifically to a problem with the kidneys. The kidneys are responsible for the release of erythropoietin in response to sensing a decrease in oxygen tension. So the kidneys sense that the circulating oxygen levels in the blood are low, or that the hemoglobin isn't bound to oxygen, and so then they stimulate the production of more red blood cells. And then vitamin D, the kidneys play a role in converting vitamin D to the active form so that the body can actively manage calcium. So in those roles, the kidneys are very responsible for the management of proper sodium, potassium, water, protein, like the urea and nitrogen, bicarb, and calcium levels within the body. And then we said that sometimes glucose is excreted in the urine as well if the blood levels reach 220 or higher. I do not expect you to be able to regurgitate this for the test. I just think that this is one of the most important things to understand within the function of the body, because there are so many drugs that work to either increase or decrease the RAS system, and this is the system that is activated when the body goes into shock. So it's really important that you understand this. So the first step is that the kidneys recognize that there's decreased perfusion or decreased flow through the kidneys. And that could be related to a blood volume problem, a blood pressure problem, even stenosis of the renal vessels, if the person is hyponatremic, or if they're hypoxic. So any sort of decrease in perfusion to the kidneys will stimulate the RAS system, the activation of the RAS system. So the first step then is that the nephron of the kidney releases renin. And renin activates renin substrate, which is also called angiotensinogen, which is the precursor to angiotensin 1. So renin converts angiotensinogen to angiotensin 1. Angiotensin 1 then floats through the bloodstream until it hits the lungs, where the angiotensin conversion enzyme, or ACE, converts angiotensin 1 to angiotensin 2. Now remember, we talked about ACE is also known as kinase, and that's the enzyme that's responsible for breaking down bradykinins. So this is where the ACE inhibitors work, but why they also cause problems for people. Angiotensin 2 then continues its path throughout the body, where it causes massive vasoconstriction, so very alpha properties systemically in the arteries and veins, causing peripheral vascular resistance to increase, which causes an increase in blood pressure. It also causes vasoconstriction, working on the alpha and dopamine receptors of the afferent arterioles in the kidneys, which slows down the GFR, which decreases urine output, which increases blood pressure by means of retaining fluid or blood volume. It also stimulates the release of aldosterone. So using an ACE inhibitor is fairly effective for managing blood pressure that's related to kidney disease or stenosis of those arteries, because it blocks both the release of, or the conversion to angiotensin 2, but then further on down the line, it blocks the release of aldosterone. So when aldosterone is released from the adrenal glands, right, where also epinephrine and norepinephrine are released, aldosterone then tells the kidneys to hang on to water, or to sodium, and water follows sodium. So that increases the blood volume, but it also increases the excretion of potassium so that we don't get hyperkalemic. So the RAS system then really works on stroke volume and peripheral vascular resistance, everything except heart rate really, to maintain blood pressure. So the increase in perfusion would be the end result of the RAS system, ideally. We talked about a lot of key phrases in our assessment of the urinary system. We talked about, the uremic frost, and I showed you that picture of the crystals, the urea crystals actually push their way through the skin and form on the surface of the skin. And then some other words that we talked about that are important. So hematuria, or blood in the urine, when it's accompanied by dysuria, so painful urination, urgency and frequency, oftentimes it's a urinary tract infection. If it's accompanied by flank pain and sometimes some white cells, a lot of times it's kidney stones. When you have that flank pain, fever, and white cells, then we start thinking about pyelonephritis or, infected kidney stones. If it's painless hematuria, we worry about bladder cancer. And when we have hematuria and proteinuria, so a lot of protein and blood in the urine, that's consistent with acute glomerulonephritis, as we talked about, rather than nephrotic syndrome. Oliguria, remember, is less than 30 milliliters an hour or less than 500 milliliters a day. The urine becomes dark and concentrated. We talked about, oftentimes starting to approach like tea-colored urine as it decreases and decreases. And then anuria is minimal to no urine output whatsoever. And this could be related to hypoperfusion. So remember, the patient who is in shock and has acute kidney injury, that pre-renal failure, might not have any urine output. So we, look to see, is our treatment of the patient or our management of the patient effective by whether or not they have adequate urine output. In end-stage kidney disease, the kidneys completely shut down and stop making urine. So with somebody who has end-stage kidney disease, we can't look at urine output as an adequate measure of hydration, or eyes and nose. We can't look at that as an adequate measure of hydration because their O's are not going to actually match. Bladder rupture. Obviously, if the bladder ruptures, there's not going to be any urine coming out. Sometimes they might leak a little urine, but what's more common is the blood at the urinary meatus. So rather than hematuria, where you just have some blood mixed in the urine, when you have bladder trauma or bladder rupture, oftentimes you'll have blood at the urinary meatus. So at the opening, when you go to put in a Foley, you would notice blood there instead. If you see that, you stop. You do not catheterize that. Okay, that would be a critical injury to the patient. And then obstruction. So sometimes if somebody has a huge stone that maybe made it all the way to their bladder and now is blocking the urethra and completely blocking urine output, that could stop urine from forming as well. This picture here is a person using a dipstick. So this is a urinary dipstick. So they have their urine. I love the fact that they actually have gloves on in this picture, and some of the pictures I found they didn't, which kind of freaked me out. And they dip the stick in the urine, and following the directions on the bottle, you read the different colors at different times. So some are, if you look over here, glucose is in 30 seconds, ketones in 40, pH in 60, but leukocytes not until 2 minutes out. And so you really do need to keep an eye on the clock when you're doing this to have the most accurate reading. So you match up the colors on the bottle, which are these colors over here on the right hand side, with the color on the corresponding part of the dipstick. Okay. So if you look here, at this bottom one, they're not quite lining up as to which one is which, but that's probably urobilinogen way down at the bottom there, and it's negative. So you see that color matches up, so that would be normal, so it would be negative. The next one up, it was protein. It looks like that one was negative also, or maybe slightly trace. The pH is normally the top one, the very first one up here, so that looks like it's okay. And specific gravity is the next one down usually, and that looks like it's fairly dilute, like maybe a 1.02. So as you're going through, you get used to reading these kind of on the fly. But just look over here at the blood for a second. I always find this to be interesting. There is negative where it's completely yellow, and then there's trace where you have little dots, or there's hemolyzed trace where the entire thing is green. So if the blood cell remains whole, you'll just have positive dots on the slide, but if the blood is very hemolyzed, the entire slide, or that entire little square, will turn slightly green. The same is true then for moderate. See how there are dots here all over it, and then if it's hemolyzed, you'll have just a green square there. Excuse me. So how we collect our urine makes a huge difference in what the dip is going to look like if we are doing a dip. So we use a dirty urine when we are looking for things like gonorrhea and chlamydia. So we might have somebody on purpose not wipe or start their stream of urine prior to collection so that we catch any bacteria or growth that's in the urethra or at the urinary meatus. So a dirty urine does have its purposes, but the person would, want a gonorrhea or chlamydia urine. Clean catch is what we use when we, or what we do when we use the wipes. We have women wipe front to back, throw it away, front to back, throw it away, sometimes even a third time front to back, throw it away. Ideally, they would start urinating into the toilet and then catch the urine midstream. Depending on age, size, coordination, illness, that might make it easier for some people than others. For men, if they're not circumcised, they need to retract the foreskin prior to doing clean catch, and then they wipe, throw it away, wipe, throw it away, wipe, throw it away. Again, start urinating just a little bit into the toilet and then to catch it in the cup, the sterile cup. With men, it's ideal that they don't put the penis inside or against the wall of the inside of the cup, just because it will contaminate the specimen or the reading. And for women, they shouldn't shove the cup up against themselves when they're collecting the urine. There's so many rules to get a clean catch urine that it's almost impossible to get one on somebody that's not really, really young, thin, and healthy. So a lot of times what ends up happening then is we have to straight cath somebody to get a sterile urine sample so that we're sure what we're seeing is actually coming from the bladder, and so we know whether or not we should be treating an infection, because with women there's a lot of vaginal contributions or just not clean enough. And then Foley catheters, remember with Foleys, we don't break the connection. Ideally, we clamp it shut and we wait until some urine collects, and then we, hang on one second, and then we draw it off with a syringe through the collection port of the Foley. For a 24-hour urine collection, remember we have our big jug. We have our big jug. You see two of them here. The brown one is the one that we give out at our hospital. We want to write on it. So a lot of times we actually write on the jug. Here there's an example where they have written on the door. And so you, at time 0, you have them void and discard it, right? And then you want to collect all the voids for 24 hours. Remember, that has to be kept in the refrigerator or stored on ice. And then at the end of 24 hours, you would have them void again, and you would keep that last void. So essentially with the 24-hour urine, we want to collect all urine made by the kidneys in a 24-hour time. This does not need to be clean catch, so they don't have to wipe, they don't have to do anything special. We're not checking for any infection. There's nothing in there that would throw off our counts. So, they don't have to do anything special other than just get all of the urine into the jug. The other tests that I want you to review, again, creatinine levels you should know, BUN levels you should know, calcium, potassium, white blood cells, and H&H. All of these, tying them in from prior learning, but they're all directly related to the health of the renal system. All right, just want to run through and review quickly, just broad overview of some of the renal problems and then some of the treatments. So acute renal failure or acute kidney injury, remember we talked about that high output failure at first. So a lot of times they go into this diuresis mode where they're releasing tons of sodium and also water. But remember, with acute renal failure, that not only are they losing sodium, but they're also losing potassium. So that's very different than some of the other problems that we've seen, where you lose sodium and retain potassium, or keep sodium and lose potassium. where we have just kind of leaky kidneys, and we're losing sodium, we're losing potassium, and we're losing water. So we're losing all three things. We're worried about dehydration, right? Chronic renal failure. Remember that the kidneys are responsible for vitamin D synthesis, so we worry a lot about our calcium levels with our chronic renal failure patients, as well as our potassium levels, things like that as well. So when you have hypocalcemia, now we've got to go back to the endocrine stuff. What did we study? We studied Trousseau sign, Chavostex, muscle twitching. We talked about cardiac arrhythmias. The calcium that is missing is being leached out of the bones because the vitamin D isn't being activated, so they're really high risk for fractures. Things that you wouldn't necessarily associate with the kidneys, but remember that we're talking about muscles, we're talking about bones, we're talking about the heart. There's other things that will go on with these people. And remember, as the disease progresses, INOs are not going to be that accurate, right? Daily weights, we talked about daily weights are the best indicator of fluid balances. So you still want to do INOs, you still want to do vital signs and check their blood pressure to make sure that they're not hypo or hypertensive, depending on, how much fluid they're losing or where they are in their dialysis cycle. And then monitor for, signs of fluid volume overload, like crackles in the lungs, edema, or even tenting turgor if you think that they're losing too much volume. So, always putting those pieces together of what fluid volume balance looks like in relation to your patient. Acute glomerulonephritis. So remember, we said that this was oftentimes after strep infection. The person has a lot of protein in their urine, blood in their urine, like we said. The kidneys, remember, like with the urea, are supposed to filter out that protein, but they only do a good job of filtering out like certain proteins and certain sizes of proteins. So with the AGN, remember we talked about that low protein diet to avoid plugging up the kidneys, right? So we don't want to put too much protein in these guys because the kidneys will get plugged up. Conversely, nephrotic syndrome presents differently, and remember they have like the smoky colored urine, and we put the nephrotic syndrome people on steroids to decrease their inflammation. And like we've been talking about all semester, steroids increase our risk of infection, right? So then we have to worry about when we have somebody on steroids, whether or not they're going to get an infection. And that's true no matter who we put them on, but definitely for nephrotic syndrome patients, we worry about steroids and infection. Wilms tumor, and thank you to Roland and Heidi again for presenting our pediatric stuff. So remember that it affects the left kidney more often than the right. It is an overgrowth of the cells within the kidney itself. It can rupture if you push on it, so we don't want to put any pressure on the abdomens. We talked about things like if you feel a mass, you don't keep palpating it, you don't ultrasound it. Because the kidney is highly vascular, you don't biopsy it. It's okay to CAT scan it, but your main interventions are going to be safety, reporting your findings or your concerns, and pre-op. So prepping the kid for surgery. Incontinence, we talked about some of the different types of incontinence. We talked about stress incontinence, so coughing, laughing, jumping, moving. Overflow incontinence, where the bladder gets incredibly distended and it can't empty on its own, but it just, kind of like the cup runneth over. Little amounts of incontinence will occur at a time. Urge incontinence, where the person just has a sudden uncontrollable urge to urinate and the bladder spasms and empties, and that's often large volume incontinence. So overflow, oftentimes small, stress incontinence, oftentimes small, urge incontinence, oftentimes just large volume. And then functional incontinence is where the person can't cognitively function to know that they have to go, or to know when and where is appropriate to toilet. So we talked about Kegels and how to do them appropriately. We talked about the social isolation that occurs with our patients who have incontinence problems and get very self-aware or self-conscious about, the smell, or about always needing to find a bathroom, or about, having to wear incontinence items. And we talked about anticholinergic drugs that are used to treat incontinence. And just remember that when you give those drugs, you have to monitor for it going the other way and the person having some sort of an anticholinergic reaction and not being able to urinate at all. Bladder cancer, we said, painless hematuria, right? That's, kind of the main thing, the main risk factor, as you guys did a great job discussing on the discussion boards as well, is tobacco, because it concentrates, or exposure to any of those carcinogens, because they get cleared by the kidneys, and then those carcinogens concentrate in the bladder and change the cells of the lining of the bladder. Kidney stones. Remember, risk factors include like dehydration, and they form, so then the urine gets concentrated and crystals form. So it's really important to stay hydrated and avoiding triggers. We strain the urine. That's a big nursing intervention. We treat for pain. We hydrate. If they become obstructive, you can get like a hydroureter or a hydronephrosis, depending on where the obstruction is. If it goes untreated, it could cause acute kidney injury, post-renal kidney failure, right? There is some controversy about diet, but with the calcium phosphate stones, a lot of times they say not to eat a diet that's high in calcium or phosphorus, and to eat instead, that ash alkaline diet like we were talking about in class. And then bladder trauma. We have our abdominal crush injuries, penetrating traumas, which can rupture the bladder. And the person usually has, as I said, the lower abdominal pain, the no urine output, and the blood at the urinary meatus. So how do we treat these problems? Well, it depends, right? The indications for dialysis are rising or symptomatic potassium levels usually, right? So we can do peritoneal dialysis for the person who cannot tolerate hemodialysis or can't get into hemodialysis. So peritoneal dialysis, remember, they have the shunt placed in their abdomen, and anytime they have something penetrating through the peritoneum, we worry about the risk of peritonitis. We talked about positioning to facilitate the installation and removal of fluid, like, you can raise the bag or drop the bag. You can also raise, the head of the bed to increase abdominal pressure to drain the diacylate back out for the patient with peritoneal dialysis. If they have hemodialysis, they have a fistula, right? Or they have some sort of a catheter. So then we worry about, infection. We worry about clots. We always check for a thrill or a bruit. So a thrill is something you feel, a bruit is something you hear. And those have to be assessed at least every shift, and then, before and after dialysis. Remember, no blood pressures on that arm, no tourniquets, no blood draws, nothing that would potentially rupture or injure that fistula. And because we're taking off so much fluid with hemodialysis, we always monitor for signs and symptoms of orthostatic hypotension after dialysis, which is actually fairly common. We see a lot of people like, in the 80s and 90s systolic after dialysis. Some handle it fairly well. Some are symptomatic nearly every single time for a day or two. If the patient has a transplant of the kidney, remember it goes in the lower abdomen, not where the kidneys normally live, right? And it gets hooked into the bladder, and it gets hooked into the vascular system in the lower abdomen, oftentimes in the right lower quadrant. You can have hyperacute rejection within the first 48 hours, or an acute rejection from 1 week to any time after transplant, which is actually pretty interesting, versus a chronic rejection, which occurs months to years. So what's the difference between an acute rejection that can occur anytime and a chronic rejection? It's the signs and symptoms. So an acute rejection still has your stereotypical signs and symptoms of rejection, where a chronic one is just almost like a chronic renal failure, where the kidneys start to fail, the person starts to develop edema, they don't feel well. The acute rejection is that febrile illness and the obvious kind of more dramatic signs and symptoms. On page 1444 in your book, they talk about the different types of transplant reactions, if you want to look that up again. And then for bladder cancer, remember we do those ileal conduits, or we do surgery, and there's some different options that we have. But with the ileal conduit, we're putting a shortened tube from the outside world to the kidneys, so we're increasing the risk of infection. So how do we minimize that risk? So one is good education and teaching about proper hygiene. But just like with a Foley catheter, remember that those ileal conduit collection bags should be draining to gravity. So when they sleep at night, they should be using a gravity drainage bag rather than like a leg bag or a small bag. They should be emptied frequently anytime that they get full, so they don't reflux back into the kidney. You're always monitoring for drainage, making sure that there is urine output into that bag. So looking for, signs of infection or signs of obstruction or signs of problems with the ileal conduit or the surgery or the kidney. All right, and last slide is just a review of prioritization. So we've talked about this multiple times, but our first goal is always to identify, is there any acute safety concern? So is the person at risk for, injury, self-harm, harm to others, seizures? Is there anything that we immediately have to address in terms of safety? And then is there a problem with their airway, their breathing or oxygen, their circulation or bleeding? And then, any neurological disabilities or changes in mental status, expose the skin, and then consider things like nutrition and hydration, and then psychosocial, is there coping problems, and then teaching. So up top, we have immediate life threats. Down at the bottom, we have long-term goals. So just, when you're prioritizing things, right, you're thinking, okay, LNA. What could I delegate to the LNA? Rock solid, stable, does not require assessment of any kind, right? So you're only going to delegate tasks, never assessments or thoughts. LPN, what could you delegate to the LPN? Well, that must be the most stable patient who needs nursing care, okay? And you guys are all LPNs at this point in time, so which patient would you feel most comfortable caring for? That's a good way to think about it, right? And then which one would the RN need to see first? Sorry, Nate just bumped my elbow. Which one would the RN need to see first, right? Or which one would you give to the most experienced RN? That's always asking for you to identify which one patient has something abnormal. That requires you to know your normal and abnormal values, correct? So you have to know your normal and abnormal values, or you have to know those critical rescues. So if they're talking about you know, a patient who has, just looking for one in the book, a critical rescue, but let's see, habit training. So do not tell patients to just wet the bed, right? So that would be something like, you know, the nurse would provide additional training or whatever to the LNA if they hear the LNA telling the patient to just wet the bed. Or on 1390 it says, infection is common in patients who have a neobladder. Teach patients and family members the manifestations of infection and the importance of reporting them immediately to the surgeon. Right, so now they're talking about ileal or ileal diversions or alternate urinary pathways. So just, you know, things to think about when you're reading and you're studying. Those would be things that I would definitely pay attention to as well in terms of prioritization. After a nephrostomy, notify the physician immediately if the drainage decreases or stops. So if there's no urine output, that would be really bad. Or if the drainage becomes cloudy or foul smelling, if the nephrostomy site leaks blood or urine, or if the patient has back pain, right? So all signs that the kidney is failing or obstructed or infected, right? So those would be like, that would be a patient that you would need to see right away. So I hope that makes sense. I think a lot of you guys are still struggling with those types of questions. And, you know, obviously there's going to be those types of questions. All right, so that wraps it up for this set, and then I'm going to do the next set.